guys, today we are going to continue with the anatomy of humerus. In the previous session, we have seen about the parts of humerus and about the proximal end of humerus in detail. In this session, we will be continuing with the shaft of humerus. So basically, the shaft is long, cylinder middle of humerus, and it is built tough with a hard cortical bone shell and a marrow-filled cavity. The key features of shaft are deltoid tuberosity, a rough V-shaped spot where the deltoid muscles attach, helping you lift your arm sideways. And then radial groove, a spiral groove on the back where the radial nerve and profunda branchi artery run. That nerve controls the wrist extension, so it is critical. On clinical note, the shaft fractures often form a twist or direct hit, can trap the radial nerve, causing a wrist drop, where the patient can't lift their wrist or fingers. In the OT, surgeons might explore the nerve during fixation using intramedullary nails or plates. We will prepare tools like guide wires or monitor for the post-operative swelling, which could mean compartment syndrome, tight muscles squeezing nerves. And then now we are moving to distal end. So it's all about the elbow. The hinge joint for bending, rotating. The capitulum is a rounded knob that connects to the radius, letting you twist your arm, feel like a turning key. And then, so this is the turning key. Here it is the turning key. And then the trochlea shaped like a pulley fits ulna for smooth bending. The medial and lateral epicondyles are knobby spot where forearm muscles attach. Flexors on the medial, extensors on the lateral. So the fossa, obliqueron, coronoid and radial fossa are dips at that let the radius and ulna move without crashing into the humerus. OT relevance, the supracondylar fractures, common in kids from falling on an outstretched arm, can damage the growth plates. And then even the nerves. We will assist with pinning and plating, ensuring the C-arm, it is a type of X-ray, is ready for intraoperative checks. Anesthesia technologist might help with a brachial flex block for elbow surgeries. Example, a 10-year-old with a supracondylar fracture needs pin. We ensure the pins are sterile and the arm is stable for X-rays. Now we are going to move to the muscle attachments of proximal end. So the proximal humerus is a hub, muscle hub. The rotator cuff muscles, supraspinatus, infraspinatus, teres minor are on the greater tubercle, while subscapularis on the lesser tubercle. Hold the shoulder joint tight. The intertubercular sulcus, a groove between the tubercles, anchors big muscles like pectoralis major on the chest, and then latissimus dorsi on the back, and teres major. So under OT angle, the rotator cuff tears, common in athletes and or old age patients, need arthroscopy. We will prepare scopes, shavers, sutures, ensuring the muscles are preserved for shoulder function. For example, a tennis player with a torn supraspinatus needs repair. We need to set up the arthroscope and keep the sterile field premises. And then the shaft and distal end, also muscle magnets. So the shaft. So these are also called as muscle magnets. So basically the shaft or the deltoid tuberosity hosts the deltoid for arm abduction. The lateral borders holds brachialis, elbow flexation and brachioradialis. And then in the distal end, the medial epicondyle for flexors like flexor carpi radialis, bending the wrist, and lateral epicondyle for extensors like extensor carpi radialis and straightening the wrist. In OT relevance, we are in the shaft fractures, the muscles can pull the fragments apart. We will assist with the alignment for distal fractures, preserve muscle attachments during fixation to maintain the hand function. In the next class, we will be continuing with the blood supply to the humerus. Thank you.